What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Godin, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. We're back in the vault, the shelter, whatever the hell we call this thing. We're in deep in the Winchester household in Brett's library, and we were kind of looking at some old books. We talked about this with some shout out to you. Got some old stuff in here. So
I got some classics.
Yeah. So obviously we're sitting down with Michael Shacklock, our second one this weekend. He's a trooper. We fed him full of wine and some good food and stuff to get him up for this. And so so last night we've taken a tour of Australia and New Zealand the entire time that he's been here. And so last night we had this crazy bottle of Velvet Glove, which is a Shiraz, and it was insane. They brought it out to us in a velvet, like a carrying case. Yeah, it was crazy. So that was amazing. That'll go in our Hall of Fame at the office. You signed it, so that's awesome. And then tonight we're having a little nightcap with this podcast with some Paradigm Merlot.
Not from Australia, but a great bottle.
No, it's from Oakville. So great bottle of wine though. It's really, really good. So,
good. Yeah, cool.
Well, Michael, you entertained us with our PTI style of some quick hitters earlier today with some diagnosis and stuff. But tonight we thought we'd kind of chill out with a little bit of a lighter conversation, if you will, and kind of talk about the misconceptions with neurodynamics. So we got some great questions and some thoughts that we thought out that we're going to let you kind of riff on. But I started down the path of the old books, and this is kind of an older book too, isn't it? Right here.
Yeah, it is.
Did you want to kind of talk us through what that is?
Yeah, sure. This is called Biomechanics of the Nervous System, Brieg Revisited. Now, Dr. Alf Brieg was a neurosurgeon from Sweden, and from the 1940s to the 1980s, he researched in detail movements of the central nervous system, brain, spinal cord, cranial nerves, ventricles, nerve roots, and so forth, dura, and so forth. In cadavers, right through to patients. He did radiology on them and saw their nervous system reposition when he did neurodynamic testing, and he figured out what certain movements could ease and provoke pain in things like radiculopathy. Now that to me was a big breakthrough because it was the first time you could see a nerve move, or between frames anyway, where you could put force on it, provoke patient's pain, change the head position, move the lumbar nerve root, and give the patient pain relief. And that's just an example. Now, he was the Leonardo da Vinci of biomechanics of the nervous system, to the point where his work will probably never be superseded or repeated. And the reason I'm impressed with it is because he did it over a long period of time. He got down to the cellular level through histology. You can see axons being bent and straightened with different positions. And he also did photoelastic modeling of force distribution in the spinal cord to try and predict where forces would go and what they would do. Now, what I'm realizing is that he was creating a general theory of physics and symptom production with what he was doing, and that all boiled down to tension. And if you think of a lumbar nerve root, it's got to pass a longer course around a disc hernia, tension, because it's shorter and tighter. It's a fine or microscopic level of evaluation, but it turns out that compression gravitates to similar mechanisms to tension, because neurodynamic tests and the tension pattern of movements are abnormal in these people, and even though it starts with a compression, it gravitates to tension. So if we get down to a reductionist level, probably the tension stuff that he did was right. Now, we look at a more superficial level through movement, or for instance, nerve root moving on and off a disc. That's not strictly tension, but at a fine level, it has to create symptoms probably through extension or separation of cells or ion channels through the tension mechanism. And so, to me, it's foundational work. I must say he's often well known in the chiropractic area, not so much in the physical therapy, although it is well known there. And so for me, that was historical, unprecedented, and foundational.
Did you have personal contact with
Yes, I did. I had the good fortune I remember the very time I started planning to meet him. It was in Switzerland, in a place called Bad Ragaz, which is it was a physical therapy type postgraduate education centre where they were getting external presenters and teachers to teach people ongoing professional education. And it's a huge old house, creaky old thing. You could swear it was haunted. It was scary. And I remember being the only person in this house that was multi-storey. It had a central area that you could look right down from top floor to bottom, and the stairways around the edges. And the students would come and stay in that place as students for residential students for a weekend or a week or whatever. So there's a lot of bedrooms around the circumference of this quadrangular building. And the only time no one was there was when I was there sleeping, because they all disappeared because the books would finish and I'd wait there for a few days between courses. So it was pretty scary. And that was, I remember one night locking my door and thinking, I've got to think about what to do next, distract myself, And so I ended up thinking, Brieg, here we go, is he still alive? And I thought, probably not, because he's probably very elderly. But long story short, I was able to go to the publishers of his first book, his second book rather, Almqvist and Fixel in Stockholm. So I wrote to them, emailed them and said, look, I would like to get in contact with this author. And they said, look, we've handed the copyright back to him because it's finished in print, but here are his contact details. So I was able to write to him, and his wife kindly replied and said, yes, he's still available to meet you. And so over the next couple of years, I planned to go to Stockholm, because I had to go there anyway for teaching. And he was about an hour and a half north of Stockholm by train, in a place called Söderhamn, and we were able to meet him. So two physios that I'd been collaborating with at the time, we got a train and went up there and met him. And it was just like a remarkable experience with this elderly man who was definitely in his latter years, of course, had a few health issues, of course, but he and his wife were still there, and I had the good fortune of meeting him, and it was a very humbling experience. The joy for me was he looked at me and said, thank you, I'm so pleased someone remains interested in my work.
What do you think Brieg's major contribution was, if you had to pick like one or two things?
Understanding how the nervous system moves. That's the big one. And the beauty of it was that he did it from many levels of analysis. Fantastic work.
Was he talking about contralateral limb movement and things like that?
Not at that stage. I wasn't aware of any of that.
But did you enlighten him on any of the stuff you were, or was that
he actually wasn't very physically capable, and so that even though we had a really nice time, it wasn't that easy, because he was not well, and we could only communicate in a reasonably rudimentary way. His wife obviously helped, of course, and so we didn't get a lot of opportunity to discuss things in detail, but it was more a sharing of a moment between us all. To me it was a joyous occasion, a very humbling occasion, and I got the feeling that he felt similar about it.
I think the other fascinating thing, the two icons in the world of neurodynamics, obviously you, but also David Butler, live 500 yards away from each other in Australia.
That's true. Yes,
that's pure insanity to me.
Yeah, that's true. It's a suburb called Goodwood in Adelaide, and actually a number of physiotherapists who have published research in this kind of area. There's not just David and me, it's some other people as well, Ellie Bell and so forth. So it's kind of a hot spot.
And then it's just fascinating too who all you've been with in your life and career. Jeffrey Maitland, Robin McKenzie. I mean, it's just, the list goes on and on about who you've been able to hang out with over the years. It's absolutely amazing.
It's been a real pleasure, real joy.
It's pretty awesome. And so this book is not available right now, but maybe in the future.
Yes, look, I published this at his permission, Dr. Brieg's permission with his wife. It's actually a reproduction of his second book, so we've changed nothing. I wanted to keep it authentic, so I just reproduced it at their permission, give them a royalty, of course, but we have been selling it, and it's out of print at the moment because it's sold out, but in the not-too-distant future, we hope to relaunch it, and you obviously will hear about that in the future.
That's awesome.
Now to the Bible.
Yeah, the Bible, your other book. So here we go. You just signed it for Brett as well. So when did this go into publication?
2005.
Yeah, a young Michael Shacklock on the cover here.
Yes, it's approaching 20 years.
Yeah.
Oh, 2005. Yeah, it's 2025. Yeah, approaching 20 years.
When you first came to Troy for a course, I remember you saying that not a lot has changed from when you first published this book. And Brett and I always talk about that when we talk about you, because so many people feel the urge to, update and have the newest and greatest and things like that, but the principles have remained the same. Did you know it at the time, or?
I'm a little naive, meaning I just felt that I wanted to say what I thought. I didn't actually care about whether it was a success, because I was probably going to be the only person who bought it anyway. And so, to me, I felt the need to organise neurodynamics for myself partly, but also so it could be distributed and disseminated to people who wanted to use it. So for me, the key points and the organisation was the critical part, and so that to me hasn't changed, because those key points are based on fundamentals such as force on the nervous system. We know that when you extend your back, you press on your nerve roots within tolerances and reason. And we know that when you flex, it tensions the nervous system. That will never change. And so if someone has a problem with those, we can then categorise relationships or clinical features to those mechanisms. And so hopefully one of the reasons it hasn't changed is because the fundamentals haven't changed.
Beautiful.
Just so we get the history right, what is Robert Elvey's major contribution? That's another major name that you hear.
Absolutely, yeah. So Robert Elvey, first, my reading of his literature, I remember the first time I saw it was in 1984, but he had written a number of papers elucidating the idea that you could create a straight leg raise mechanism for the upper limb. So the brachial plexus tension test was what he pioneered in the 1970s, where he did some cadaver studies and arm movements to show that the cervical nerve roots moved with arm movements. Now, that was foundational, because we then realised that we could move and test nerves as we could muscles, tendons, or joints. So it was a really big step forward. Great credit to Robert Elvey.
Yeah, amazing.
It's great. Well, we're 11 minutes in, and we haven't even talked about the topic of this conversation. So that was a good little history lesson stuff. So the whole purpose is we want to talk about the misconceptions with neurodynamics. And so, we kind of explained neurodynamics, what it is. We've given some layman's terms for it and stuff. But let's talk about maybe. I can speak for myself. As for the first 6 or 7 years that I was introduced to neurodynamics, I was bastardizing it and didn't really understand what the hell it meant, and I just thought it was sliders and tensioners, and some people get better, some people don't, and the classifications weren't really there in my mind until I saw you speak. So our first one is neurodynamics and neuromobilization. Those are the same things, right?
Good point. So that leads me nicely into the statement that one of the probably the biggest misconception about neurodynamics is thinking that neurodynamics and neuromobilization are the same thing, as you said, because they're simply not. There's a lot of overlap, because part of neurodynamics could involve neuromobilization, but there's a ton of extra stuff in neurodynamics that isn't entirely directed at neuromobilization. We have diagnostic categories based on functional disturbance, and what I really like about the movement systems that are available these days is you have your categories, you have your mechanisms, clinical features, and particularly with movement and kinesiology, but we haven't until not too long ago had the functional categories. And so if you have someone who's got really severe pain, they do not need neuromobilization necessarily. What they might need is pain relief, so we can unload nerves as a part of treatment. Now, there's not neuromobilization, but it is neurodynamic treatment.
And I think that's the big mistake that you'll see like across the board. I think when, the rest of the world is using neurodynamics or using, some kind of treatment with neurodynamics, you might be using a static opener and maybe resting the nerve root. So I think that is a major misconception, and that was a mistake I was definitely making myself early on.
Well, and that kind of is our next point, is force always needs to be applied.
That's a good point. Now, with neuromobilization, we are always applying force to the nervous system. But the most common problem in the clinical syndromes we see in nerves, in the musculoskeletal context, is too much force. It's pressure. Usually lumbar nerve root or carpal tunnel syndrome, the most common. Too much force, and we apply force with neuromobilization. So to me, there's a contradiction. And probably, if we can use descriptors for therapeutic effects, the gold standard is curative. That's rare. The next step down will be corrective. Can't cure it, but we'll fix parts of it. And the third one will be adaptive. And I reckon neuromobilization is an adaptive procedure because we're applying force to something that's already forced on. So somewhere along the line a change occurs. Might be improved viscoelastic function, it might be reduced sensitivity, altered blood flow. So that to me is an adaptive thing, but it's still applying force. And it's, to me, it's not entirely logical.
That's
Perfect.
good. That's good. And then I think another thought of mine was when you're putting force into one area, we talked about it's not always force. If you're putting force into one area, you're obviously putting force into another area. Said another way, when you're tensioning the median nerve, the cervical nerve root has to be involved with that as well, or the force has to be equal on both of them, depending on.
Yes.
It doesn't really matter the sequencing, doesn't matter anything like that. The force is the force.
So Taylor is, for the audience here, Taylor's leading me really well here. And so the next misconception is that when you apply force to one area, it always produces the same or increased force in another area. That is simply not true. And the reason is that part of my research recently is to look at contralateral nerve root behavior when you do a neurodynamic test, and it seems to apply in the cervical region. We have validated it in the lumbar region. So if you do a straight leg raise on the right side, it moves the spinal cord down in the canal, and that change in position reduces tension in the nerve root on the other side. Now that meant, look, I remember when we submitted this as a cadaver study and so forth to the general spine, and one of the reviewers, it was very, very direct, and this is often the best way to learn. They said, you researchers look like physical therapists. And it was, really? It's anonymous, of course, so they don't know, because you physical therapists have a habit of making the measurable important instead of the important measurable. Now that hit me in the guts, as it would, but it's true. We often overestimate the value of a data point or data and misinterpret its value. And for me, presumably the reviewer was a medical practitioner, and they're thinking surgically and medical biology and stuff like that. Absolutely right. But what we didn't explain well enough was the reason we're interested in contralateral testing is that if we can move the cord down and unload the other nerve root, we can give people pain relief through unloading nerve roots. Really important. So the misconception again is that when you load nerve roots on one side, you're also doing it on the other. No, you are usually unloading the other.
It's pretty amazing. The biomechanics of that, I still grapple with them, and it makes sense the more I hear it, but it's still a difficult concept.
You got to see Michael's model with the TheraBand, and then it makes perfect sense when you see it.
I'll put a link because you have that on your YouTube page.
Yes, I do. Yeah.
And I think once you see it, everything starts to make sense from there. But it is a difficult concept, and something that even in practice, every once in a while, I get to close my eyes and say, okay, so if I do, you just kind of got to take a step back. But
are you the pioneer in that thought, Michael? Did you get that from someone else? Or?
Yeah, I remember that. I remember when it happened. I've not seen that anywhere else. And in 1989, when I was doing the master's program in Adelaide, which is heavily influenced by Maitland, of course, Mark Jones and Maitland and so forth, we were given an assignment every fortnight approximately, and each of us had to study a subject and present it to the group. There were sort of requirements, and one of them was an expansive review of the literature. And if you did everything really well and summarised the subject perfectly, you only got a good mark. What they wanted you to do, wanted us to do, was be creative. And they said, we want to see something new. And so I made these working models, got some wood and nails and elastic bands, and created foramen and so forth on a model, and realised when you do the nerve roots on one side, the cord comes down and it reduces tension on the other. And so I thought, wow, this is cool. And I must admit,
did you sleep that night?
Well, I was really interested. It was like a eureka. And so, although when I presented it, it wasn't actually well accepted. Understandably, it's pretty new and not studied and so forth. But I kind of has sat on that for a long time and presented on courses as a hypothesis. But in the last few years, we've actually validated those mechanisms in cadavers, fresh cadavers, in neurodynamic testing, competing against a sham and a control group in responses, and also measurement of spinal cord movement, showing that that's a requirement. If you can't move the cord, you can't cross over to the other side. So that's part of my PhD, which is how to unload nerve roots, etc. And so it's a validated mechanism. Now, what's really nice is that there's a French anatomy group who we did not communicate with, who studied the same thing subsequently and showed the same results. So it seems to be generalizable.
Well, I think too, seeing it with the patients has probably been gratifying also, I would think.
Yeah, absolutely. Yeah. You can actually do a straight leg raise, or it's usually hip flexion 90, knee extension 90 degrees, and someone who's got sciatica, ipsilateral. Now, if you do it, obviously if you straighten their knee, it's going to hurt them because it's a straight leg raise. But if you swap sides and do the same thing on the other side, often their leg pain diminishes. And to me, that's gold for pain relief.
Yeah, that's amazing.
Absolutely. What about the mechanism of nerve sliding, Michael?
Mm-hmm.
If I just extend my arm like this, the nerve slides correctly? Correct.
Okay, that's a good question. Now, this goes to the statement that not all nerve sliders are sliders.
Yeah.
Now, the history here is that the nerve sliding stuff is partly studied contemporarily as in ultrasound technology. We're using ultrasound imaging. Now, the problem is that no one walks to work with an ultrasound head on their forearm, so the view the ultrasound head gets is artificial. But it emulates bone because the ultrasound head allegedly doesn't move much, neither does bone when it comes to nerve sliding. Now, nerves are dependent on their immediate interface. So if you have a tendon that is next to a nerve, looking from an ultrasound onto the nerve as if it were bone is artificial, because the tendons move with the nerve or in the opposite direction to the nerve. The bone doesn't. And so what we have done is we have created an artificial situation where we're actually getting a wrong impression of how nerves slide. And for instance, if we're thinking of the carpal tunnel, if we extend our fingers and thumb, the tendons move distally, of course, with the fingers, and so do the nerves. Does the nerve a little bit, but less. But the problem is that if we extend our fingers and then extend our elbow, the tendons go distally, the nerve moves proximally. There's a very different mechanism from what's been measured in the studies. There's a huge amount of sliding relative to the immediate interface compared with doing, I hate to say it, but my love-hate relationship with social media errs toward the hate side because what you see on YouTube is often incorrect. You see beautiful sliders, lovely, but they often don't slide, because they're not taking into account the immediate interface for the nerve, which is often tendon, and particularly in the wrist, it is tendon. So bone is irrelevant when it comes to analysis of the sliding, but the studies emulate it as if it were bone. Mm-hmm. So there are misconceptions on how to slide nerves. Now, if we want to go to one of the more common sliders, which is lateral flexion, IPSI, and then elbow extension for a slider of the nerve root in the C-spine, that is not a slider for the nerve root in the C-spine because the foramen moves with the nerve root. So they move together.
It's like relative movement. Yeah.
It's all about relativity, yes. And so if you move the foramen with the nerve root, it ain't sliding. It's just moving together. So it's moving in space, but they're together, so they're not sliding on each other. So unfortunately, the distal slider for the nerve root in the neck is contralateral lateral flexion, elbow extension, wrist extension, which happens to be a tensioner. So the early tension is a slider, but late tension is less sliding, much more tension. So there are misconceptions, and it's all about relativity. We know the nervous system is Newtonian, it follows the laws of physics, but when you get to sliding, you've got to think of Einsteinian mechanisms, or figuratively, if you will, sliding relative to the interface. It's much more complex than we thought, and unfortunately, a lot of us are getting it wrong.
Right.
It's true. What about... This is one that I wrote down because this is one that I thought the neurodynamics test is going to give you the diagnosis or the pathology, the disease that you're dealing with. You're going to be able to do a neurodynamic test and it's going to say, yep, this is whatever.
Yes, that's a really good one. Now, if you think of a disease and pathology, that's detected with things like radiology, electrophysiology, the kind of medical tests. Now, if you do a neurodynamic test, there are people who have a paralyzed nerve, bad results on electrophysiology, but they can have a perfectly normal neurodynamic test. And unfortunately, there is a group of it out there where the diagnostic efficacy studies at best are imperfect, at worst they're worse than flipping a coin. And what I mean by that is if you have carpal tunnel syndrome, that is a constellation of clinical features, of course. It could be a neuropathy found by electrophysiology, but you could also still have an abnormal test. Someone could have normal electrophysiology but have an abnormal neurodynamic test. And so what we now know is that with great work from Jeff Bove, many of you hopefully you would have heard of. If not, don't worry, we're going to talk about him at some point. And so if you do a neurodynamic test, what it detects is sensitivity and impairment of movement, and that goes right back to the fundamentals in 1995 when I wrote the first paper describing neurodynamics. Integration of mechanics and physiology is how it happens. They're dynamically interdependent, and so if you lack movement, you could hurt. If you're sensitive, you could hurt. And so the neurodynamic test picks up a subgroup of people who have movement-related nerve pain. It's not a medical diagnosis, it's a functional diagnosis. And me being a physical therapist and you guys being chiropractors, we are functionists. Great, really important area to work in. And so you could have inflamed nerve from Jeff Bove's work. He's shown that you can have normal conduction through inflammation, but it can be hypersensitive. So they're not testing for the same mechanisms between electrophys and neurodynamics, and so there's a bit of a discrepancy. Not always a close relationship. We're detecting a subgroup, which is a really important subgroup.
And this kind of leads us to the next misconception. It's a perfect segue of that a neurodynamic test would tell you the site of entrapment.
Yes.
And that I think that is one of the biggest misconceptions. If you took everyone who attended our seminar this weekend, before the seminar started, I would bet you 100% of that room would have thought that neurodynamic testing is going to tell you the exact location where the entrapment site could potentially be. Can you explain how it's not 100% rule? You're gaining information from that as you're sequencing the neurodynamic test,
yes.
But that you probably wouldn't push all your chips in as far as knowing exactly where the site is going to be.
Yeah, that's a good question, good point. So the history of that is that my thesis for my master's in 1989 was on neurodynamic sequencing. So the idea it's a hypothesis that at that time, of course, it's based on observations that if you do, say, wrist extension, then elbow extension, abduction of the shoulder, then contralateral lateral flexion, that you're focusing the forces on the nerve in the wrist, because that's where you start. But if you reverse it, it's on the neck. And so the idea was you'd compare them, and maybe one being worse at one end than the other would tell you where the problem is. That's actually, I agree, that it gives you ideas and sort of an introduction and variables to consider. it makes you think of that area. But we've done some study in the lab up in Barcelona where we're actually using microstrain devices to see what happens to the nerve elongation with different sequences. And Michel Copperters and Bob Nee have done research in this area as well, where it turns out that if you use the same ranges of motion at the end of all tests, no matter what sequence it is, the elongation is actually the same. So it's not actually the sequence, it's the range of motion at the end of the test. And so if I were to extend my wrist first without the elbow extended, I could get a lot of wrist extension. So I can load the tissues locally really well, and then I can add nerve. But if you then return it all to the same angles of all joints, that's reversed. And so we've also studied this in the lab with using the same ranges of motion that happen when you do this in a conscious subject, but in the cadaver. So we've kind of got a profile of which joints will move how much when you do a neurodynamic test with a specific sequence, because the person says, well, that's stretching, you better stop. So we know where we should stop and the ranges of motion at each point. And what we show is that when you use the patient or the individual conscious person response range of motion, you put it into the cadaver, then you have something. You don't have as much elongation where you finish last, and you have it much more when you start first. And so that's a helpful thing, but it's not a determinant, because many other factors determine where the nerve is sensitive and what might be causing it. So I agree, it's a factor, but it doesn't actually tell us where the problem is, because it's a long continuous system. It's moving all that long part, and so, and also with physiology spreading around nerves and so forth, it's not so easy. And so I agree, it is a misconception, and so I would use other aspects of assessment to figure out where the nerve problem is mostly located.
Where does differentiation play into that?
Okay, differentiation is when you move the nerve in the area of attention or of relevance without moving the neighbouring musculoskeletal structures. And so if we have a wrist pain, the differentiating movement is to hold the distal part of the limb stable, and you move the lateral flexion. And in most situations, we know that moves the nerve at the wrist, but it does not move the tendons and muscles. So that we are emphasising nerve in the differentiating manoeuvre. And so clinically, if we reproduce a patient's pain with a neurodynamic test, and we move the nerve from another area without moving MSK in the area of the problem, and it does not change, we are moving the nerve, patient's pain doesn't change, it's not the nerve. So they do not go to the neurodynamics hospital, they stay in the musculoskeletal hospital. So initially it's an elimination technique, but you can actually switch it sometimes into an implication technique.
Exclusion criteria.
Yes, exactly.
Inclusion, exclusion criteria, which we had a great conversation about on the way to Brett's house today. I mean, I think that's a mark in all the systems that we really enjoy. Everything has an inclusion and exclusion criteria. We were talking about palpation on the way here. Palpation in the spine has an inclusion, exclusion. You have hypermobility, probably not going to manipulate that area. No different than neurodynamics. You have inclusion to put it in the neurodynamics hospital. You have exclusion that says it is not.
But to Michael's credit, I think neurodynamics has probably done the best job of kind of mapping out what that exclusionary criteria exactly looks like, And I think that as a clinician, I mean, that gives you so much information, whether or not to know that this is actually a neurodynamic case or it's not. And then, all of us within this room, and we all have tools for the case that is not in the neurodynamic hospital. But knowing that is such a critical part of decision making for the future.
I absolutely agree, and I think one of the things I like about systems is they're efficient. You have to think less because you know your stuff, but what they lack is often flexibility. So you need 4 things: inclusion, exclusion criteria, which we now have. You need diagnostic categories or functional categories, or dysfunctional categories. You need progressions for each one of them, and you need an exit strategy. Now, if there were an inclusion or exclusion criterion for neurodynamics, it would be abnormal neurodynamic tests, they may be included. If it's perfectly normal, they would be excluded.
I think, too, it's been really refreshing for the last couple of days to hear you remind us that we do have the ability to palpate, because there's people in the world that are telling us, whether it's a joint, muscle, soft tissue, trigger point, a nerve, that there's no reliability in palpation. So before we hit the next one, what is your take on that?
Yeah.
When people tell you that Michael Shacklock is not able to palpate nerves, does
yeah, well, my position is don't give up. You've got to keep going because I trust what I feel. Now, for example, as I mentioned on the course, you can feel a piece of grit on your trackpad. You know it's there, and if you look carefully, you often can't see it. You flick your hand around and brush it, it disappears, and you can now slide your hand without a little lump on your finger. Now, it's very sensitive, very specific. Now, if we come to diagnosis with palpation, I think the problem is not so much the palpation, it's the interpretation of what happens. And so, if I press on a nerve, I can feel a nerve. I've done it in cadavers and then opened them. I'm confident that I can feel a nerve, and it's being tested. I've worked with anatomists who can't find nerves, and I say, palpate it, here it is, and they cut it open, and there it is. And so they're surprised that I can palpate and find a nerve. Now, I'm not saying everyone's reliable, but it doesn't mean don't do it.
right?
You know, optical retinal cell activity and vision don't correlate, but don't close your eyes.
I think you had a great analogy today, like with a plumber who's screwing, you know, even people outside of our profession, like they still are using feel and touch to kind of know what's wrong with, in their respective crafts.
All day.
Yeah.
And so whilst there's a lot of criticism of palpation, I trust what I see. I trust what I feel. And unfortunately, particularly I feel for young people in the industry these days because they're reading PDFs. They say, don't do that. It doesn't work. Well, you have an experience. I suggest practice, learn, and that will help you develop the experience to trust your observations.
Right.
One of the most important things in clinical practice, trust your observations.
Right.
It doesn't mean we get everything right, but there are studies now that show, well, Nina Schmidt's group has shown that if you palpate a nerve and produce a response in healthy subjects, from day to day, the responses are really reliable. And so don't give up. It's not solved, but to me, I'm going to keep trusting my observations.
And the research in the MDT world also has shown that if you've gone through the coursework, then you are reliable. So compared to somebody who hasn't been certified in a technique system, which makes perfect sense, but it's worth repeating. So if you go through the coursework and you've been trained a certain way, then you can be reliable. But if you take a random off the street and you ask them to do a neurodynamic test, well, we wouldn't expect them to get the same findings as Michael Shacklock.
Yeah, exactly.
Yeah.
A lot of it is about learning, getting your skills right. Absolutely.
Yeah.
And if we sort of take it through to extreme situation, the lady I saw yesterday with the upper lumbar problem, buttock pain and stuff. If you said to an average health practitioner, can you palpate the cervical spine? I reckon you'd go to the neck. Don't you reckon? And if you had 100 even young health practitioners who weren't fully qualified and said, please palpate the cervical spine, I reckon they'd all go to the neck. Now, the question is how intricate the reliability is tested at. Do you go for C5 or you go for C6? But if you go for the neck, you got it right. So the threshold for reliability is to some extent a little bit artificial. If you press on an area that's really quite stiff and tight, I'm okay with thinking it's stiff and tight.
Right.
And if it's stiffer and tighter on one side, I'm okay with picking the correct side. So the part of it is threshold and sensitivity. If you focus on the minutiae, it will get wrong because often it's the wrong level of analysis.
Right. And like this, Dr. Levitt, that sage over there, he said the most powerful diagnostic tool that's ever existed is a human hand. So as technology continues, we have artificial intelligence, we have MRIs, we have CT scans, but at the end of the day, we have all the years of experience that are built into our hands that I think...
Yeah, and there's a study by Ali Rushton's group that shows that when physiotherapists are mentored by senior practitioners, they get better clinical outcomes than the ones who are not mentored by senior clinicians.
That's ironic.
And so,
thanks for being my senior citizen, Brett. I appreciate you.
Wow, that's tough.
So the experience counts. You know, it's a kind of a shame that we have to have this discussion, because to me it's obvious, but you know, a lot of people don't accept it, so you kind of feel you have to prove it. But so these subtleties, the nuances, as Stu McGill says, you're playing jazz. You know, there's complexity, there's intricacies, there's uniqueness, and we have general laws of what the body, general structure, but individuals are so unique. And look, there are 8 billion of us on this planet. I've been a clinician for 40 years, and I've never seen two people the same. And so if you can't deal with uniqueness, then you are going to be a generalist, and you will lack choice. If you can get specific with your hands included, you have more choice. You can do more. I feel you can do more with the patient.
I think in Jeffrey Maitland, that was one of his themes, where systems are really important early on, but then you got to be nimble enough to kind of like think outside of your system when the case calls for that.
Yeah, I agree. Absolutely agree.
Mm-hmm.
Yeah.
It's beautiful. We crushed it.
Is that it?
Any ones that we missed that you maybe thought of or anything like that, Michael? Anything to get off your chest here? This is your chance to kind of right the ship if we haven't discussed anything.
I think one of them would be that we can't produce tissue changes. You know, we're in the lab. If you for instance, put a bit of tension on a nerve manually, so you get your finger on the nerve and pull on it and fiddle, you oscillate, it actually changes position. It gets softer in that area, and it develops a little ripple. But if you come back 15 minutes later, it's gone back, and you didn't do anything to it. So it's retreated, it's viscoelastic and so forth. So it's quite dynamic. And if you go to Jeff Bove's work, he's shown that you massage in a bowel irritation model with they get an abrasive and rub the bowel and produce an adhesion. You massage it for 2 minutes after the surgery, and they don't get as big adhesions. And this is the sort of stuff that people don't really pay attention to. And unfortunately, I think the social media thing is actually really good because you can distribute information, but it's made it harder to figure out what's accurate. And so you see this stuff, it doesn't produce tissue changes and stuff like that, but actually it's been shown that it can. And so you see people, you might look at scar tissue and on the skin, and you massage it and do stuff to it, you soften it. You can change tissue. So people like what they read because they read what they like. And so there's a lot of bias out there, and I would really like people to read the literature expansively and don't invest in an outcome. And when you invest in the outcome, you lose the truth. And so that other one is you can change tissues. I feel it in nerves. If you massage a nerve, you do stuff to nerve, you can reduce swelling in a nerve. Been shown with MRI now. And so don't underestimate the power of the hand, your specificity and your skills, and their effect on the tissues.
I don't know how it is in Australia, but one of the most overly prescribed medications in the United States is a classification of drugs called gabapentin. Mm-hmm. So your Neurotins, your Lyricas, this class of drugs used to treat peripheral nerve pain. What's your take on the use of gabapentin? Is it...
Yes, look, I have seen patients who are using it, and I'm not seeing a lot of benefit.
Right.
There's quite a small. My understanding is that there's quite a small therapeutic window. So once you get to a therapeutically effective dose, you're often close to overdosing in terms of side effects.
Yeah.
And so
slowing of speech. Just slows everything.
They get drowsy and they don't sleep the same and stuff like that. So drugs are not really my main area, but I'm not seeing great effects with drugs and nerve pain, but in our case, we could look at the function, like neurodynamic testing, mechanical sensitivity, and work on those to help people's nerve pain. Very powerful effects in some people.
You and I had a really good conversation on the way to the office this morning. I almost drove past the office so we could keep talking about it. And that was the clinical reasoning process, pattern recognition, how good clinicians have the ability to kind of triage and know what to do at the right time. Can you speak of that and what you've noticed over the years makes for good clinicians in that area?
Look, I feel very fortunate to have learned clinical reasoning from Mark Jones, who was an American physical therapist from, I think it was Iowa, and he went to Adelaide, Australia, to be with Jeff Maitland, of course, and he could develop quite a close relationship with Jeff, and Jeff would, for instance, do a presentation on a patient, and Mark or someone would say, well, why did you do that? And he said, oh, that's easy because this, and this. And my understanding, rightly or wrongly, is that Mark was the guy who said, well, that's exactly what we need to learn. We need to learn how you think. And he broke it down into the cornerstones, one of which is pattern recognition. And it's known that experienced clinicians ask fewer questions and they come to the answer more quickly. And so that is a really important part of clinical reasoning, pattern recognition. And being a neurodynamic therapist, I've seen quite a few neurodynamic patterns, so I kind of get through it quite quickly. And I must say, I probably don't explain it well enough, but that is a really important thing. And I remember that the patient with gluteal pain we saw, I said at the end of it all, that is archetypal. That's exactly what I expected to happen. And a comment would be, well, because I've seen the pattern before. And that is a really important part of all clinical practice, including neurodynamics.
Which a young clinician doesn't want to hear that, but the reality of it is part of it is getting reps and experience in what you're doing.
Yes, it sure is.
Yeah.
And finding a good mentor. We talked about that earlier.
That's a good comment. And I've been approached by younger people to say, look, what should I do to develop my career? And that's one of my comments. Just find a mentor who's willing to spend time with you, who's not particularly invested in a style or a type of treatment, except to educate you on how to include it or exclude it. I mean, we do get our favourites, of course, and that's kind of natural. But someone who's pretty balanced in their opinions is a really important mentor to have.
Mm-hmm.
I think we always say the younger generation, the lost art of the apprenticeship. I feel like as time goes along, the younger students, they don't see the benefit of, even if you're not getting paid for it, just being able to hang out with somebody who is, able to show you kind of the ins and outs of the craft. I think that is for some reason kind of gone away, and I don't know why that is, but that's kind of a shame.
I suspect it's time pressure, availability of information. If you can get a quick Instagram post on. Or with an infographic, then it kind of solves it, doesn't it?
Right.
Well, it doesn't really, but it makes you think it does.
Well, I think everyone now too thinks they're the expert. Like I definitely in my career know my place and where this is all going, and I think it's funny. Like some of the younger clinicians are. I don't know, not that they haven't earned the right, but they just haven't seen things enough to have an opinion on it,
Yeah, it's all about learning.
Yeah.
I agree. So my advice to, younger people would be try and connect with a mentor who's got broad experience and is willing to impart their information. And look, I'm a bit of an old guy now, of course, entering that era in my life. And I said to one of the people at the course today, I sort of feel it's part of our obligation as more senior people to impart this stuff to the younger people, because without that, what do you have?
Yeah, that's awesome.
That's how you leave your mark too. That's absolutely. So, well, I'm out of wine, guys.
Yeah, does that mean we're done?
It's been a long day. Michael's been talking to us nonstop for the last 4 or 5 days, and so we're just super appreciative of your you coming here. Number one, you teaching us, you being graceful with your time, and for the work that you've done for this profession and for musculoskeletal health in general. So it's truly an honor, and we're just appreciative of you. So
well, thank you very much. It's an honor for me. It's a great opportunity, and I look back on why I started getting into physical therapy is to help people. Still there for the same reason.
Yeah.
Thank you.
Preach.
Yeah, awesome.
Beautiful.
Thanks again.
Yep. Thanks, Michael. Let's go drink some more wine. Hang out. Talk about something besides neurodynamics for a little bit, maybe.
Of course. Of course, yeah.
See you guys. Have a good day. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.